Hello, everybody. Good afternoon and good morning to our friends in United Kingdom. We welcome all the participants on live webinar on urodynamics and functional urology. And first of all, I'll give a brief introduction about the webinar and the faculty, and then will be the speakers, they'll make their presentations. So basically, the aim of the webinar is to provide the trainees and the practicing urologists the basics of the urodynamics and give the practical tips regarding the diagnosis of the functional problem which we encounter commonly. And it is also part of the expert sharing across the globe. Our friends in the United Kingdom and Pakistan, we are thankful to them that they have given time for this webinar. And basically will be, the pattern would be that we'll be following the basics, how to perform the urodynamics, and then how can we diagnose the common cases with urodynamic studies. And basically we have the urogynecologist with us who will guide us through the different urogynecological problems and which require the urodynamic diagnosis. So first of all, we'll go through the introduction of our esteemed speakers. Professor Zeeshan is with us. He's a consultant urologist in Scotland, and he is surgical tutor to the Royal College of Surgeons and Physicians, Glasgow. He has been kind enough for providing the collaboration with the Royal College of Surgeons and getting the activity CME accredited. Professor Nazli is a leading urogynecologist of the country, and she has got a huge experience in treating the urogynec cases. She is also with us. Professor Raheela Mohsin is professor of urogynecology at the Aasem University Hospital. She is also member of the International Incontinence Society. She will be providing the insights into the diagnosis of different incontinence cases in females. Dr. Shahzad Shah is a consultant urological surgeon, and he has got the special interest in the diagnosis of the functional urological cases. Dr. Belal was supposed to join us, but unfortunately he met an accident. We are praying for his rapid and smooth recovery. Dr. Rizwan will be taking up his presentation. Dr. Rizwan Hamid has special interest in neurourology and incontinence, and he also sits in the board of International Coordination Society, and he is the consultant urological surgeon at University College London. Dr. Aasem Masood Chaudry is also a urological surgeon in United Kingdom, Bedford Hospital, and he is also in the visiting faculty of the Pakistan Kidney and Liver Institute, Lahore. The activity is CME accredited. We have shared the link in the chat box. You can follow the link, and by completing the survey, which is provided in the link, you can claim the credit hours. Thank you very much. So with this, I'll be requesting Professor Nazli to start her presentation. Professor Nazli, you are with us?
Yeah, I'm with you. Thank you so much for your kind introduction. And let me share the screen with you. And can you see the screen now? Can you see my screen now?
Yes, Professor Nazli, we can see the screen. You can start your presentation.
Okay, thank you very much. So thank you very much for inviting me and for providing me with this opportunity of presenting at this August forum. I'll be talking basically about the fundamentals of urodynamic practice, when to do them, why to do them, in a simple introduction, basic procedures. The main aim is to review the recommendations of urodynamic testings based on ICS recommendations and to introduce those fundamental urodynamics for the beginners and for further clarification of the practicing clinicians, and also to make specific recommendations for clinical practice in view of international guidelines. The main learning objectives will be to learn the standardized terminologies for objective lower urinary tract dysfunction and to learn the basic principles of these objective testings, and understanding that that bladder is not a very reliable witness and symptoms can be due to a variety of dysfunctions. And also that tests have got their inherent variability and they are not like 100% foolproof, and they are influenced by the circumstances in which we perform them. And also to learn to systematically analyze and evaluate those results. So like any other investigation, a good urodynamic practice also needs that there should be a clear indication for performing the procedure and appropriate selection of the patient group. The equipment has to be standardized and the protocols used should also be standardized. Like any other investigation, even in urodynamics, you have to keep in mind the clinical context in which you are performing them, because every investigation, when it needs an interpretation, we have to keep in mind the clinical features of the patient and what we are looking for exactly. The measurements have to be as precise as possible with a good quality control. Evaluation should be correct. Documentation should be complete using the standardized terminology, and not to be, it cannot be overemphasized that staff training has to be very specific, and regular performance evaluation of the staff is also needed. So why urodynamics are clinically relevant? Because these are the ones which demonstrate the reservoir function of the bladder relevant to the clinical features. But to interpret them properly, we need to have information like patient symptoms and signs. And for that, we can use different questionnaires which are available. I'll be talking about voiding diary, and then to have a voiding diary in hand before you start the procedure gives you a prediction or an estimation on which you can predict the cystometric capacity of the patient. We perform free uroflowmetry before we start the formal filling cystometrogram, and then a post-void residual urine estimation as well. So while we are performing we are going to talk about performance of the urodynamic investigations. What clinical tests before that are important, in view of randomized controlled trials and international recommendation. The cuff stress test, we are familiar with this. It involves filling a patient's bladder to at least 300 ml before starting the procedure, or if the patient has just come to your outpatient clinic, we instruct the patient to urinate 2 hours before the test and then to have 2 cups of water. And then after 2 hours, we call the patient in. Patient is asked to cough while standing with the legs apart or in a position, taught me, where it is directly visible, the urethral meatus. And the cuff stress test, based on randomized controls, appears to be a reliable screening test for stress urinary incontinence, especially if a conservative therapy is contemplated. I've mentioned it here because urodynamic investigation is not available everywhere, and frequently our colleagues, who do not have this facility, they get stuck up in this, like what to do if we do not have a facility. So we cannot underestimate the importance of preliminary screening tests, because we do perform them even when we are selecting the patient for sophisticated investigations like urodynamic investigations. And further evaluation with these more sophisticated tests is required if you are suspecting detrusor overactivity, or if any irreversible surgery is being contemplated, then it is sensible to proceed to more objective documentation of the abnormality. We do perform urine analysis before subjecting any patient to urodynamics, because it is an invasive procedure and it is highly recommended in all patients with incontinence. And if the patient shows microscopic hematuria, then we go for further evaluation of that before we proceed on to urodynamics. So I spoke about voiding diary. The importance is that International Continence Society recommends inclusion of voiding diary in the initial evaluation of patients with lower urinary tract symptoms. Voiding diary is important because it gives us a record of maturation behavior, which is completed by the patient herself. And that gives the patient, it is simple, non-invasive, inexpensive, and it brings the patient, into the dynamics of diagnosis and treatment. So empowers the patient. Patient is actively involved in the management of her own condition, and more objectively, she can understand whatever dietary advice or fluid modification or conservative advices we are giving to her. Secondly, it can also give us a useful tool, during the treatment and after treatment, to monitor improvement, both subjectively and objectively. And in the voiding diaries, the frequency of maturation at night is the single best parameter, which is very helpful in discriminating between the two commonest causes of incontinence, the stress incontinence and the urgent incontinence. And if we combine the daytime maturation frequency with the largest single volume voided or the mean voided volume, that further enhances the discrimination power of these diaries between these two type of incontinence. So once we have made up our mind by initial evaluation of the patient, which of course includes history and examination, and then these simple maneuvers which I just mentioned, then we select the patients who are subjected to urodynamics. This is a term which is used to describe a series of diagnostic tests to evaluate voiding disorders. And the goal is that we want to give an objective diagnosis to the subjective feelings of the patient, and we want to give it a standardized terminology and standardized diagnosis. So the main role is discriminating. Main role of urodynamics is to discriminate between different types of incontinence, differentiating the severity of stress incontinence, identifying any complicating factors, for example, outlet obstruction, detrusor hypoactivity, detrusor overactivity, which can and possibly may complicate your postoperative results if you are subjecting a patient to surgery. So it's a good idea to do these tests before that. And according to the expert consensus opinion, urodynamic is the only way to understand why people are continent or incontinent, and that is helps us in an attempt to gain understanding in what exactly is going on with them. So uroflowmetry is considered the first line screening test for patients who are undergoing urodynamics. We perform a free uroflowmetry before beginning, and obviously when we complete CMUG at the end, again patient has another uroflowmetry. So the initial uroflowmetry gives us when we ask the patient to perform this uroflowmetry in their preferred position with minimum possible discomfort in an atmosphere with minimum possible anxiety, and respecting the patient dignity as much as possible, as much privacy as possible. And we repeat the test if we think that the result is not representative of the patient's abnormality or what she has been stating. And once she is done with that passage of urine, we measure the residual volume of the urine, because that gives us an overall estimation of the capacity of the bladder. Plus, we also know, after uroflowmetry, when we are beginning the test, where we are, what is the initial status of the bladder, how much volume of urine is actually there before we start the procedure. Uroflowmetry will give us an idea of the entire maturation, of the final result of the entire maturation process, which, of course, comprises of detrusor function, opening of the bladder neck, and then urethral conductivity. And we see for different parameters in that, when they include the flow rate in ml per second, the flow time, the time to maximum flow, and we see that the flow rate is the time to maximum flow is completed in the initial 1/3, and then as the volume decreases, the flow rate starts declining. The area under the curve gives us the voided volume, and the pattern, the bell-shaped pattern of the curve, indicates a smooth detrusor contraction, which is creating this uroflowmetry. The ICS recommendation on uroflowmetry, the key feature is that uroflowmetry and post-voidal residual urine are the simplest non-invasive voiding measures, which should be performed on all patients with incontinence and voiding dysfunction, especially if they are being subjected to invasive procedure, and especially if you've already tried the conservative measures like medication intake restriction, modification of the fluid intake. So then these are the simplest investigations which should be performed. And we see in this slide that here, this is the normal graph, but below this, you can see that the flow is interrupted. So we see smaller peaks, and they kind of indicate there's a voiding dysfunction. And here also we see that this is not a smooth bell-shaped curve. So pattern is interrupted. It's a sawtooth pattern here and interrupted peaks here. So all of them have got different interpretations. They can indicate poor contractility of the bladder. They can indicate outlet obstruction. So they are to be evaluated in the line of clinical information available, in the light of clinical information available. So then we start with the filling cystometry. And in filling cystometry, it is important that, like any other machine, like even when we stand on a weighing machine to assess our weight, we need to reduce to correct the zero error, so that you do not start with 2 kg already recorded on the weighing machine. And that's exactly true with this machine as well, that when you perform filling cystometry and you attach the transducers, you want to zero the machine because you do not want to start at a higher pressure, which will give you a false result to begin with, or with a negative pressure. And detrusor pressure cannot be a negative. An agreed lower limit is 10 centimeter of water. And then we also have to know that while we are talking to the patient, she is alive, and the body vibrations, they are also going to transmit some vibrations in these. So we perform a cuff test to begin with, just to balance the response. Sorry, this postcoital resolution. Right. So what is the recommendation of International Continence Society on cystometry? So cystometry is the most accurate tool for evaluation of bladder dysfunction and filling. A positive cuff stress test and a single channel CMG may be the minimum accepted test before you perform surgical intervention on any patient. And the invasive test is recommended, especially if we are contemplating that there are certain complicating factors as well in this patient. For example, if a patient already has a mixed incontinence, or if a patient already shows the symptoms of voiding dysfunction, then performing a surgery straight away on her can be very disastrous, because that can be post-operatively, that can present as urinary obstruction or a more aggravated voiding dysfunction. So in cystometry, we fill the bladder transurethral. We fill it transurethral, and a measurement of intravesical and abdominal pressure is performed. And we end the cystometry with when the patient says that she cannot hold the urine any longer, or she asks the permission to void, or if the patient is a child, or the patient is of blurred consciousness, then if there is an involuntary loss of the total bladder content, that also ends the cystometry. We generally perform the test in the lithotomy position, and sterile catheters are used. For bladder, we use a double lumen catheter of 6 to 7 French. For rectal pressure, we prefer a punctured balloon, and that is just an attempt to reduce any false pressure of the abdomen by a filled balloon. And we fix the transducers adjacent to the meatus. Patient is comfortably seated and then covered. And like I said, that the transducers are zeroed, and for the reference point for zeroing the transducer is upper edge of pubic symphysis. And with placing the transducers at the correct place, we take the initial resting pressures, and the agreed upon resting pressures in supine position are 5 to 20 centimeters of water. In sitting, they are supposed to be higher, and in standing, they are supposed to be even higher. So we perform the test in supine position. So position of the bladder, position of the transducer is at the upper edge of pubic symphysis. When we set them there, it means that we have zeroed them, and we assume that intrarectal and intravesical pressure are at identical levels. We try our best to keep them at identical places, but there can be some variation. And generally, there is an assumption here that they are just identical. And then according to ICS standards, urodynamic pressure is measured as any pressure above the atmospheric pressure. We use a saline solution at room temperature. And while we are performing the fluid filling, we start at a low rate, 10% of the expected capacity per minute. And you must be remembering that I said in the beginning that we want to know an estimated approximate capacity of the patient, and that is generally we get an idea from voiding diarrhea as well. Because if we start filling the bladder too rapidly, that also provokes an earlier sensation. Similarly, if it is not at the room temperature, the saline you're using it is too cold, that can also provoke a premature desire to pass urine. So these standardizations are important. And then we fill the bladder until there is a strong desire to void. And meanwhile, we are going to ask her certain questions, and I'm going to come to that in the next slide. The end of cystometry is indicated on the trace when patient asks a permission to void or the pump is stopped. So we record the bladder sensations and also the volume at which those sensations were claimed. The cystometric capacity is recorded in mLs. and it is followed by a uroflowmetry again, and again a post-void residual urine. And we say that the total capacity of the bladder is voided volume plus the post-void residual urine left. So the questions which we ask the patient during these tests are, number one, tell me the time when you perceive that your bladder is not empty anymore. So that is the first desire. And that has to be differentiated from the sensation when we just pass in the catheter. It should not be the sensation of just catheter present in the urethra. So we tell her that you have to tell us that when you start feeling that there is some urine in the bladder, but you can hold it, don't want to go to the washroom straight away. And the next question is that when is the time when you normally would go to the toilet? Tell me, we are filling the bladder and we are simultaneously asking her that, please tell us what will be the time when you will like that, under normal comfortable circumstances, you would go to the toilet and pass urine. And that is recorded as first desire to void. And then we ask her, when is the time when without any pain, she will like to visit the nearest restroom, even if she's out in the market or if she's busy at some social place. And that is recorded as a strong desire to void. And when the patient says that she cannot hold the urine any longer, that is recorded as the cystometric capacity. So first sensation of the bladder filling is recorded. And I again repeat that this is the time when patient first becomes aware of the bladder filling, and this has to be different from the sensation that initial catheterization caused. And then the first desire to pass urine, which is the time when patient under convenient circumstances normally would go to toilet and pass urine. And then a strong desire to void when there is a persistent desire, overriding any other activity, that she should go to the washroom and pass urine, but it should not be with a fear of leakage. Because when there's a fear of leakage, that is not just a strong desire of void, that is probably we have reached the maximum cystometric capacity, and that is recorded separately. So this is the maximum cystometric capacity, and commonly it is around 400 to 500 ml. We should not be going up to very high values like 800 ml or things like that. And so maximum cystometric capacity is where a patient can no longer delay micturition. And if we overfill the bladder, we have to keep in mind that if the bladder is overfilled, that also slows down the detrusor contractility, and that also subsequently ends up in a poorer stream. So it is important to stop at the maximum cystometric capacity. Then at the same time, we have to be aware that patients are not as clear on reporting these sensations as clear we are how to ask them. And patient can have vague answers and altered sensations, like a vague feeling of abdominal fullness, vague feeling of bladder pain. So bladder pain should not be there. If patient is complaining of bladder pain, that is an abnormal finding, and then that needs to be investigated separately. And urgency is where the patient has a sudden compelling desire to pass urine, and that is generally associated when the detrusor is overactive. So generally the first sensation to pass urine is at around 175 to 250 ml of urine, with, of course, this is a plus minus range. The first desire to void is around 270 to 450 ml, and strong desire is between 420 to 700 is the upper limit. Generally, it is plus minus 100 ml, so up till 600 ml is acceptable. Then there can be altered bladder sensations. Like I said initially, patient can be excessively responsive to these sensations. And the increased bladder sensation is defined as a very early first sensation of bladder filling, or a very strong desire to pass urine, which occurs at very low bladder volumes, lower than the ones which I just mentioned, keeping in view their plus minus ranges as well. And reduced bladder sensation is defined as a diminished sensation throughout the process of filling cystometry, throughout the process of bladder filling. Like you have reached 500 ml and patient has still not reported the first desire to pass urine. So that is reduced bladder sensation. And then absent bladder sensation, which means that throughout the process of filling, the patient is not reporting any symptoms, any sensation at all to you. You are asking her questions, but she is not giving you the symptoms. So the sensation. So one catheter we placed in the bladder, and the other one we placed in the rectum. So the one in the bladder was giving us the vesical pressure, and vesical pressure is a combination of abdominal pressure and the detrusor pressure. So there is no way that we are measuring detrusor pressure directly. We are measuring vesical pressure, which is a sum of abdominal pressure and vesical pressure. And the rectal catheter is measuring abdominal pressure. So once we are subtracting the abdominal pressure from the vesical pressure, we get a subtracted cystometry, and that is automatically given by the computer, the urodynamic machine. We are not calculating it manually. So that is why it is called subtraction cystometry. And once we have completed the investigation, we report. And while we are reporting, it is better that we specify the position in which the test was performed, the catheter size which was used, the fluid type, the fluid temperature, filling method and rate, and then the recording technique, sensations like they are marked as FD.
Professor Nazli, can you finish your presentation in next few minutes?
So then there, it is important to mark them. So normally, so what is the bladder compliance? That refers to the volume pressure relationship of the bladder, and it measures the stiffness of the bladder. Good compliance is a large volume and low pressure. 400 ml per centimeter of water is the good compliant bladder. Normal bladder compliance is if the compliance is less than 30 ml per centimeter of water, it is classified as low compliance. So this is a normal trace where we can see the vesical pressure, the abdominal pressure, and this is the detrusor pressure, which is calculated as a subtracted record. This is the presentation where we can see that the detrusor is overactive, and this is reflected as a rise in the vesical pressure, and here is the leak with the overactive bladder. This is the graph which is showing with cuff, rise in abdominal pressure and a rise in vesical pressure with relatively quiet detrusor, and there is a leak. So this is reflective of stress incontinence. So finally, coming to the recommendations, according to the American Urogynecology Association guideline, clinicians may perform multi-channel urodynamics in patients with both symptoms and physical stress incontinence who are being considered for invasive, potentially morbid, or irreversible treatment. This is just a view of our urodynamic clinic and our urodynamic laboratory. Thank you so much for your patience.
Thank you very much, Professor Nazli, for summarizing such a huge subject in a very short time. We'll be moving to next presentation, and that would be by Professor Raheela, Mohsin, and that is on the role of urodynamics in the diagnosis of incontinence among the women.
So the topic is the indications of urodynamics while you evaluate a woman who presents in the urogynec clinic with the urinary incontinence. So that's a very controversial topic, and there have been changes in the last decade with while we should be doing urodynamics, we should not be doing urodynamics, and that keeps on changing. And my colleagues Aasem and Shahzad, we have met in various conferences. There was a time when we could not do any intervention, surgical intervention, unless you do the urodynamic studies. But now who cares? And why don't we care? So my topic basically is focused around, shall we be doing urodynamics? What purpose does it serve? Is it of any benefit? So I guess if the slide share is okay, I should. Can we make it like a on a big slideshow? All right. So this is what I'm going to cover, and I'll be talking my evidence-based. We actually are not permitted to digress with the evidence unless that you excel in the subject and you profess over the subject and you make your own evidence. Otherwise, we have to very strict, like anywhere else in the world, the strict litigations and the accountability if we digress from the standards. So basically, urodynamic, as the ICS defines, is the study of function and dysfunction of the urinary tract by any appropriate methods. By any means that there are many methods which comprise the urodynamic studies. So, and why do we need various methods? Because there are spectrum of symptoms that the patient presents. Is not just the incontinence alone. If somebody sees a cough, leak, when I cough or sneeze, that's stress incontinence. But that person may as well be having hesitancy or urgency or incomplete voiding or poor stream. So it's a spectrum of lower unit tract symptoms that the patient presents with. Even nocturnal uresis itself is a separate monosymptomatic or polysymptomatic nocturnal uresis that requires sometimes evaluation by urodynamics. So the classification by the ICS is the storage phase and the voiding phase. And what do you look for in the storage phase? You look for, is the uterus stable? If this is overactive, is this overactivity phasic, or if this is terminal? And if there is no activity, it's just acontractile or neurogenic. So during the storage phase, you do, as the Nazli said, you do ask for the sensations. It may be hypersensitive or hyposensitive, or they may be absolutely absent sensations. But then you keep a record of it, and then you conclude and try to reach to a diagnosis. And similarly, you can, as we are looking at the blood, because in the clinic, the patient presents with the bladder symptoms. And we are, as you all know, that bladder is not a reliable thing for the symptomatology. And of course, not for the urethral. Urethral, for the males, because they have a significantly long urethra. So this, you can trust on the symptoms, and you can ask. So in the clinic, the UFM is always there by and large. All the urology clinics have it. But in the female, the urethral functions, they would mimic the symptomatology of bladder functions. So storage phase, urethra may be normal or incompetent. And in the voiding phase, urethra may be normal or it may be completely abnormal. So what is this picture? This is just, by the way, a change. Try to have a closer look at this. Somebody is trying to do weightlifting, is in the gym probably. Somebody is trying to play soccer. So this is a physical activity, and this lady is laughing when the child is trying to read. So if you do all these activities and if you leak, then of course this is a stress urinary incontinence. And what are the other types? The other types is the urgency incontinence, and one may have both, mixed urinary incontinence, combining the urge and the stress incontinence, and then other person may not have any symptoms and just bladder fills and leaks, which is overflow incontinence. And my gynecologist colleague, obstetrician colleagues rather, they love the fistula total incontinence. When they have the vaginal fistula, then there's no voiding and the urine dribbles all the round the clock. So this is how we see the patient in practice, that patient may present with frequency, urgency, and nocturia. When they leak, this is wet OAB. When they don't leak, still it is dry OAB. If this is the urgency incontinence, then this will be one type of incontinence. If leaks correlating with that picture of physical activity, laughing, coughing, sneezing, that's SUI. If somebody has both, this is mixed incontinence. So this is what we see in our practice, and this is where we get into trouble for any intervention. So because you see, the pathophysiology is when somebody has the urgency, that will keep on going to toilet, increase frequency. When somebody is frequently voiding, that leads to the reduced volume, voided volume per maturation, and probably reduced capacity. And this, if it occurs at night even, then the night frequency, if somebody has a bad schedule like the doctors do the night duty, that's not the nocturia. Nocturia is when you really have to wake up from the sleep and go to the toilet. That comes in combination with urgency and frequency to make a spectrum of OAB. And all these things lead to the bad incontinence, which requires sometimes the urodynamics. Well, this is favorite of gynecologists. We see this thing very frequently in urogynecology clinic in combination with, trust me, urgency, frequency, nocturia, incomplete voiding, recurrent UTI, stress urinary incontinence, on walking, on coughing, on bending, during sexual intercourse, and round the clock. So what is it? You deal the pelvic floor disorders and you do urodynamics, but you don't. But sometimes you have to. So when do we do urodynamics in such a case? Well, my favorite is the standard cough test. Ask the patient to abduct the legs with as wide as the shoulder width, and then pass the urine and with a comfortably full bladder. If you see the leak on coughing, straining, then this is objective testing of stress urinary incontinence. But what if this is negative in the clinic? You still have to treat the patient. So you treat on the basis of history. All right, stress test, okay. Q-tip is most of the research purpose. You do the pelvic assessment. Here, hardly anybody understands what is the pelvic contraction. Neurological testing, of course, somebody has to be neurologically competent to remember the voiding frequency and is orthopedically competent to make it to go to the toilet. If somebody is not mentally competent, has severe orthopedic issues, then that's not our patient. We do the PAT test only for my research purpose. Voiding diaries, of course, it gives a clue about, in both, in stress incontinence, in OAD, both. Urodynamics, so that's the main topic. When do we do it? In combination with EMG, yes, with pelvic floor disorders, I always do it. Video, sometimes, yes, with the congenital anomalies. Cystourethoscopy after the urodynamics, before urodynamics, that's a big question mark. But I know my urologist colleague would love to have cystoscopy before urodynamics. So that's just the practice. So which urodynamics? The simple one, UFM, CMG, VLPP is my favorite to establish a diagnosis of urodynamic stress incontinence. Because female urethra is really short and urethral pressure profilometry is hard to perform, but sometimes I do it. And of course, EMG and video is an option. Ambulatory, we don't have a TKU. So this is just a repetition of what the Nazli has said, so I'll just skip on it. And leak point pressures, yes, I do it. Detusa, what is the cutoff? My cutoff is, I don't follow the books anymore. My cutoff is, I hope that you all know the stress incontinence has two types, the anatomical or the urethral hypermobility and the intrinsic sphincter deficiency. My cutoff is 60 centimeter of water for the ISD and 60 and 120 for the urethral hypermobility. If somebody has 60 and above, I have peace of mind going for Birch or Sling. If somebody has 60 and below, I would be very skeptical about the Birch. So you see, unless I do the urodynamics, I'm very skeptical about doing Birch, and Birch is my one of the still favorite procedure. So this is our MMS system machine. Aasem and Shahzad would love it because this is so-called so far the best. And this is ambulatory, which hopefully we'll get soon. And this is the diagnosis that we established. We ask the patient to cough, and if there's no detrusor contraction and there is a leak, then this is urodynamic stress incontinence. Okay, so now comes the tricky situation. The patient has presented with prolapse. She's asymptomatic for any urinary incontinence. What should we do in practice? She has a massive eversion. You're doing the vaginal hysterectomy, pelvic floor repair, one or two of the pelvic apical suspension procedure like PCOS or the uterosacral suspension or the SSF. And with the dissection, she might as well be symptomatic for SUI afterwards. And there you go with the litigation, sometimes annoying patient. You don't want your patient to be angry. So what to do? So let's get the evidence. The latest evidence is when the patient had no symptoms and they performed the urodynamics, a total of 98 patients. Look at the stats. The detrusor overactivity was found in 30. Easy to treat even if you miss it on urodynamics because all that you require is to add anticholinergics. But urodynamic stress incontinence was found in 17. So these are the patients, and you remember that you have to reduce the prolapse when you do the cystometry. So these are the 17 patients which can put you in trouble if you don't do the urodynamics, or I'll come to that. It's not mandatory. It's not even ICS, and IOGA doesn't say that you must do. I come to that how do we deal with the incontinence, stress incontinence, even if you don't do urodynamics. And mixed is the same problem. So there's the same study there where they compared the King's Health Questionnaire in London with the urodynamic diagnosis. Now look at this patient symptomatology. How unreliable is this? Patient is saying that I have absolutely no urgency incontinence, and your urodynamics says yes, it was present in 18. When the patient says I have a mild incontinence, the urodynamics says it was present in 5. And in the sphere, even there were 3 cases, but urodynamics says in the 2 it was present, in the 1 it was absent, with the sphere incontinence now. So this kind of relationship, like out of 82, 26 were saying the machine says the symptoms are reliable. In 56, the bigger number, machine says the symptoms are not reliable. So what do you do then? So this study, by the way, concluded that the data showed that an accurate pre-surgical evaluation of patients with prolapse is incomplete without a structured, validated questionnaire. This is, I firmly believe in that, and trust me that our history taking is designed on urogenital distress inventory. My fellows, they constantly use that structured questionnaire. Even I love this King's Health questionnaire due to the high proportion of abnormal King's Health questionnaire and urodynamic findings. In presumably asymptomatic patients, the study says urodynamic is a must. Well, you have the right to agree or disagree with the study. Let's look another evidence where they compared this, how reliable is this conventional urodynamics with the ambulatory ones. So when you go through these kind of studies, this is not very latest, this is 2009. So they are doing the urodynamics, the conventional thing says the urgency is present in 4 cases. And when they did this study with this ambulatory thing, it was very normal in out of these 3 patients. So which makes 75%, actually huge number. All right, doesn't really matter, you treat with anticholinergics in any case. If they're symptomatic, they'll be fine. But yes, if you have to do surgical intervention, 18 numbers stress incontinence, the conventional urodynamics says the urodynamic stress incontinence present in 10, which is a big number, 56%. And ambulatory says in none. So now what do? Urodynamics is not present by ambulatory. You trust ambulatory one, which is very expensive, not at least not easily available in developing countries, and same goes true for the mix. So then, do you trust conventional, that the one we have, and do you trust ambulatory? Or like me, you don't trust anybody? So I have my own recommendations. Look at my experience over 20 years. You just listen to the patient's symptoms, and the duration of symptoms really matters. I don't value the symptoms of 3 months duration. I value the symptoms which have some impact on their quality of life. Ask the patient to prioritize the symptoms. Which symptoms really bothers her? Stress or urge, or even if equally bothers both, then treat both. Counsel the patient. I take good 45 minutes to let them know about what is occult SUI and what is de novo. So that if they have this symptom after my surgery, radical surgery, they would not be complainant of this thing. So your counseling plays a major role if you are to go for the prophylactic sling. And we do, I would say 50% of the cases, we do the prophylactic sling. And then, of course, with this kind of history taking and practice, the urodynamics is really plus minus. But well, I would still do before purge corpus suspension, and in any case of neuropathy, like sense of incomplete voiding, recurrent UTI, I would go for the urodynamic studies. This is my own slide. This you will not find in any textbook, and my fellows adhere to this. And we find it very, very good. We're going to publish this as well. So now another difficult scenario, one of the very common presentation in my clinic. This is 51 years old, obese patient, borderline diabetic. Her BMI was, by the way, 34. She's nulliparous. She presents with post-wide dribble, urinary frequency, urgency, incomplete voiding, leaks on coughing and sneezing since 1 year, with a very bad impact on her quality of life. She denies any history of UTI. So what do you do after the urine culture and DR is negative for anything? The knee-jerk reflex, my colleagues would agree with me, urologists, they would do the UFM and PVR. There you go. The UFM shows the voided volume of 482, with the time that she has taken in voiding is 125 seconds, 1.5 minutes, and look at the average flow rate, 4.4. So what does it signify? My colleagues, urologists would say obstruction. I would say reducer activity, and the debate would start. So let's look at the post-wide residual, 255, still a lot to be done in the bladder. So what do you do? In such situations, of course, you would agree with me, urodynamic is the answer. And as the evidence says, urodynamics are the only methods to evaluate the pressure situation in the lats during storage and emptying. So there's no controversy. We have to do urodynamics. So the aim when you do the urodynamics, my fellows, this is mandatory that they would ask the research question. They would just formulate a question that these are the patient's symptoms, and they would look that can we reproduce the symptoms while we're doing urodynamics? Are we able to provide a pathophysiological explanation? Are we providing the objective functional test of the bladder functions? And what is the question? What do I want to know about this patient? So this is how the urodynamic is made reliable for a reliable diagnosis. You need to ask, am I doing this test to establish the cause of nocturnal enuresis? Do we want this to rule out neurogenic bladder before any intervention? We don't do urodynamics for pure SUI, pure UUI, or even for mixed. We don't. So this is what the ICS has recommended for the common practice, conventional indications. Mixed, I said I don't do this. Surgery for SUI, I don't do this. Cough test is good enough. Normal UFM, unless that there is some research question, I won't do. Failure to respond to conservative, yes. Refractory IB, I will do the urodynamics. Unexplained frequency, no. Recurrent UTI, yes, sometimes after the cystoscopy. Here I am with my urologist colleague. Recurrent UTI, do the cystoscopy first. Suspected voiding difficulties, yes. Failed incontinence history, of course, yes. And neurogenic, a big yes. So my take-home message would be that severe stress incontinence, previous pelvic radiation, previous anti-incontinence surgery, please do urodynamics to establish a new diagnosis, or even if the urodynamic stress incontinence is the diagnosis. Overactive bladder not responding to anticholinergics, more than 3 months duration, of course you have to do this. Urinary incontinence with voiding dysfunction, yes. Voiding difficulty with UI and pelvic organ prolapse, which is not explainable with the degree of prolapse or has an element of detrusor underactivity. Poorly definable or inconclusive history to support urinary incontinence, associated with diseases which can affect the function of blood's pelvic floor, for example, diabetic neuropathy, neurogenic. Here I am emphasizing on the term neurourodynamics, Parkinson's disease, Alzheimer events, CVA, spinal cord injuries, prolapse or intervertebral disc, Sprucer sphincter dyssynergia have to be ruled out. So these are the few important concrete diagnoses, clinical diagnoses, which really require the urodynamic evaluation. I thank you all. But my last comment is that remember, it's an art. Performing urodynamic is not, and this webinar will not enable, cannot enable anybody to perform urodynamic. No, I firmly believe that no, these 2 days or 3 days workshop will enable you to perform urodynamics, because I believe that it's an art, not pure science. I thank you all for your patient listening.
Thank you very much, Professor Raheela. I think we had all the plans for a workshop as well, but COVID prevented us from doing the hands-on activity. I think it would be a good initiative that following this webinar, once the COVID things settle down, we can go for a hands-on workshop as well. Thank you very much. Now I would invite Dr. Shahzad Shah to take over the screen and present his topic about the overactive bladder cases.
Opportunity to come here and be with you guys. Let me just, so I work at Watford General. It's a district hospital just northwest of London, has lovely countryside, has a Premier League football club, and is home to the Warner Brother Studios, which makes the James Bond and the Harry Potter films. So I will go straight to the case discussions. It's been very enlightening to hear Dr. Professor Nazli and Raheela. And so I'll put all that you've been listening up till now into some clinical context and just see how we can marry these things together. I'll just come up with some scenarios. So this is a lady. So this is a lady who's been canceling her trips because her constant, as what she thinks she has, constant urinary infections were grinding her down, and she felt there aren't any enough female toilet facilities, as she kept having urinary leakages. So she comes for a quick consultation to get some antibiotics, but when you look at her MSUs, none of them had grown anything, and frankly, she felt no antibiotics has really worked on her. And she was a bit surprised to be leaving with a bladder diarrhea rather than a prescription. So whenever you come across such patients who you suspect have functional issues rather than other problems. Take, as with all good medicine, take a good history and decide if the incontinence is stress incontinence, urgency incontinence, or mixed incontinence. And when you have elements of both, which is both leakage on stress and urgency, find out which symptoms are more bothersome. Always take a good history with regards to the medication. Medication such as prazosin, which is an alpha adrenergic antagonist for high blood pressure, relaxes the bladder and can provoke stress incontinence. Furosemide, as we all know, leads to more urine production and can lead to incontinence, which the patient verbalizes just leakage. ACE inhibitors can lead to dry cough, and that can also provoke stress incontinence. And unless you get rid of the offending cause, whatever you're doing down below will really not help the patient much. Ask about snoring, ask about asthma. Snoring, sleep apnea causes a negative intrathoracic pressures. This can lead to release of hormones, which lead to diuresis at night. And so in my practice, I think if you're not diagnosing at least 1 to 2 sleep apnea patients per year, then you're probably not teasing her symptoms enough or the patient's symptoms enough. Do a urine dip to rule out an infection and hematuria, as they need investigating and treating separately. Use a bladder diary, which is the most important tool a functional urologist has for at least 3 days to evaluate incontinence. Examine the patient for presence of any palpable bladder prolapse and the pelvic floor tone. Other types of incontinence that we're not much aware of is leakage when we rise. This can be due to stress incontinence when intra-abdominal pressure rises, or it could be urgency incontinence when the gravitational receptors trigger a detrusor contraction. And these are things you can tease out later. Leakage without warning is often non-specific but important. It can be urgency incontinence if the patient reaches her threshold bladder volume triggering a contraction, or even stress incontinence that the patient really can't verbalize. Leakage when arising from the bed is a non-specific symptom, but more commonly urgency incontinence. Leakage during intercourse is seldom volunteered. Coital incontinence is usually due to stress incontinence, but orgasmic incontinence is usually more related to detrusor overactivity. What are the red flag symptoms when you take a history? Any patient with visible hematuria, persistent microscopic hematuria in patients 50 and above, any patient with a suspected malignant mass, recurrent infections or suprapubic pain need to be evaluated otherwise and not in a functional clinic. Your first line treatment, and this is what we follow in the UK. It might be different in other parts of the world, but I will take you through what we do here in the UK. So we start off with, in fact, when the patient reaches us, they've already been to the primary healthcare system. So the GPs would have gone through the first line treatment with these people, and often also the second line treatment. And when they end up with us, they've tried a few of those things that I'll go through now. So we always start with the first line treatment, which is you reduce their caffeine intake. If those patients are overweight, you need to get them to reduce weight. This is evidence-based, and a reduction in weight, a documented reduction in weight, would also tell you that the patient is trying to engage with the system. If the fluid is very high, if the fluid intake is very high or very low, then modify, aim to spread over the waking hours of the day, and ask women to complete at least 6 weeks of bladder training as initial treatment before you do anything or you prescribe any pharmacotherapy. What is bladder training? This requires a commitment and takes some time to work. It works best when combined with drug treatment and not particularly effective in immobile patients. Keep a diary and of the frequency and volume of urine passed as a baseline and something that you can compare with in the weeks to come. You will tell your patient to ignore the usual urge to pass water and then go at timed intervals. Start with a short interval first, e.g., every 30 minutes, and then build up every 5-10 minutes once you achieve your target. And over a period of weeks and months, the patient will generally notice improvement. This is all evidence-based. You then come to pharmacotherapy. We start with antimuscarinics. Offer a woman a choice of anticholinergics. Start at the lowest recommended dose. If they have troublesome side effects, we have transdermal preparations here that can be tried. You review them at 6 to 8 weeks when maximal benefits should be apparent, and only titrate the dose up if you feel the response is suboptimal. If one drug is ineffective or not tolerated, it is reasonable to offer another from the same class. And depending upon your hospital guidelines, we usually go for the cheapest second best option. Discuss the common side effects, including dry mouth and constipation. Do not use oxybutynin in frail elderly women. There is now a big hype with regards to anticholinergics and early onset dementia. And so watch this space. We may have to change the recommendations with regards to the anticholinergics as first line in people above the age of 60. Always consider topical estrogens if they are pure storage lots with the ladies who are postmenopausal, not HRT, but topical estrogen, as this is evidence-based. So what does how do the parasympathetic, the anticholinergics work? They block the receptors which lead to detrusor contraction, and they basically inhibit involuntary contractions, as opposed to the beta-3 agonists, which actually stimulate receptors and increase relaxation. So anticholinergic medication, if you carry them on for, you can't carry them on for long term, as you can see very well over here. After a year, about half of the patients would have given up on these, mostly because of side effects. And that's where the mirabegron comes in. It's a beta-3 agonist, was developed in the last few years. It doesn't have the troublesome side effects of the anticholinergics. And we have another couple of beta-3 agonists around the corner, viabegron and solabegron. Viabegron is nearly FDA approved, and solabegron is now in its phase 3 trials. And hopefully, these do not have the enzymatic interactions that you would find with mirabegron, so even more safe. Obviously, if the patient has very high blood pressure, then you need to prescribe this with caution. So I'll just quickly summarize what I have said. Decide whether incontinence is urgency or stress or mixed. Rule out infection and red flags and treat accordingly. For overactive bladders, offer bladder training first, then pharmacotherapy. And if these fail, we then perform urodynamics here afterwards for possible more invasive options. Choose the cheapest antimuscarinic first, but avoid oxybutynin in the elderly. Consider vaginal estrogens, and always consider bladder training and supervised pelvic floor physiotherapy. This is just intravesical Botox being administered. You can either inject it into the detrusor, or you can raise blebs within the mucosa. I try to do a combination of both, but there's no hard and fast rule of how you really administer this. So I'll just come on to another case. Functional urology is not only females. We'll take a case of a 72-year-old male who's had low urine tract symptoms for the past 5 years with a weak variable stream. He had a painful micturition if he waited long enough. He also has storage lots which are more bothersome with frequency, urgency, and nocturia. His flow rate was 12 mils per second for an avoided volume of 190 mils and had about 70 mils of post-void residual. He was diabetic and hypertensive. He takes beta blockers, ACE inhibitors, and oral hypoglycemics. His IPSS score was 15 with a quality of life of 4, making him unhappy. Digital rectal exam revealed a 52 cc smooth prostate. He was offered a TURP, but that he declined. According to EUA guidelines, whilst you are investigating LUTs, you can request a PSA if you think it can change management. His was done, and this was not 2.6, so within normal range. His IPSS score for storage lots was higher than for avoiding lots, and despite this was offered tamsulosin as a first line. These are all true case reports. He was reviewed at 8 weeks when he noticed a slight improvement in his frequency and stream. However, there was no change in nocturia or urgency. He had the occasional urgency incontinence. However, his quality of life had not improved. His flow rate was 16 mils per second on tamsulosin for avoided volume of 140 mils and had about 45 mils of post-void residual on the tamsulosin. His ultrasound prostate volume was calculated to be about 70 mils. He was offered finasteride. He stopped that at 3 months because of erectile issues. However, he continued to complain of frequency and urgency. His post-void residual was less than 100. His fluid volume chart showed a daytime frequency of nocturia of 600 to 700 mils, getting up 2 to 3 times at night with an overall fluid volume output of around 3 liters. A fluid adjustment was advised and an anticholinergic added. At 8 weeks, there was no change in nocturia, but he noticed an improvement in urgency with the minimal dry mouth. The dose of the anticholinergic was increased and his IPSS improved to 10 with a quality of life score of now 2. So it's a significant improvement. So this is an interesting case which highlights useful conclusions. If you always listen to the patient first, take a detailed history, you won't need to go into much detail with other invasive investigations. This patient related his symptoms to BPH and treated at the onset as BPH only. However, with storage lots, just tease out his symptoms a notch further, as these patients need customized approach. Nocturia is a whole topic in its own. You can carry out a workshop on nocturia, and I think it's beyond the remit of today's discussion. But nocturnal polyuria can be managed by reducing the urine out, the production, especially at night. And we can discuss that later if there are questions. Urgency was the major cause of the quality of life deterioration, but this was treated last, and an appropriate treatment plan kept the patient on treatment. Do I have, can I carry on, or we are running short of time?
Shahzad, you have a few minutes.
How many?
You have a few minutes more.
Okay, so I'll just quickly discuss this other case. So this other patient, Mrs. Akram, had been diagnosed with urgency incontinence. She benefited with anticholinergics and later with mirabegron, but now has refractory symptoms. So in your own mind, just think of what you would do next. And so we reviewed the history, a bladder diary, and examined again. And this time we proceeded on to urodynamics as we'd exhausted the first and second line treatment. Her bladder diary showed obvious detrusor contractions with no change in the abdominal line. So this is detrusor overactivity. So what do we look for in much has been said about urodynamics, and I'm not going to delve into the urodynamics again, but basically you would look for evidence of detrusor overactivity, evidence of stress incontinence on the filling phase, bladder compliance, and the maximum bladder capacity that you would already. So we tend to fill the patients after having looked at the bladder capacity, the frequency volume chart. There's no fun in instilling more than what the patient normally would take. So this patient was discussed at the multidisciplinary conference. We don't make decisions on our own if the patient needs to have invasive treatment options. The first and second line treatment can be done primarily, but if the patient has refractory symptoms, we then proceed to urodynamics and then have the patient discussed at an MDT where a urologist, a urogynecologist, a pelvic floor physiotherapists, the urology nurses, and sometimes the colorectal surgeons are there. And so this lady was then offered botulinum toxin. How does the botulinum toxin work? There is the acetylcholine vesicle, which would, in association with some proteins at the synapse, the exocytosis machinery works in harmony with the vesicle and these proteins at the synaptic level. It's a combined process. What Botox does is to cleave the SNAP25 proteins from the SNARE proteins, and so this exocytosis machinery fails to assemble, and so the acetylcholine remains within the vesicle and is not discharged into the synapse. It's a reversible process. The efficacy of Botox for idiopaths is about 40 to 90%, mean of 70%. It's much higher in the neuropaths. The effect lasts from 4 to 10 months. The side effects include pain, infection, bleeding, and no benefit requiring further maintenance. Self-catheterization, it has a retention rate now, but ICS has standardized doses. So for idiopaths, you would inject 100 units, and for neuropaths, depending upon the severity and the detrusor pressures, 200 to 300. And retention rates previously with higher doses was in the order of around 15%, but with the ICS now standardizing dose, the retention rates are between 6 and 8%. So what if Botox fails? You can, we have the privilege of having the sacral neuromodulation here. What this basically does is we get the patient to we insert leads into the S3 foramina, and the patient is then connected to an external generator, goes home, wears the external generator for 2 weeks, and then compares the bladder diary. And if there's a 50% reduction in the patient's symptoms, they go on to have the permanent pacemaker implanted in the buttocks. This is useful and recommended as a second-line treatment. This patient then comes after 3 years, still symptomatic, as the neuromodulation had to be explanted due to infection. She is severely symptomatic. What can be offered? A clam is the way forwards if the patient has good hand function and able to self-catheterize. What it does is you bivalve the bladder, and it usually is down to the level of the UOs. If you really need a good result, just making a small patch onto the top of the bladder would not really help. You really need to bivalve the bladder and patch, increase the capacity of the bladder. Make sure the patient can self-catheterize, otherwise this is a contraindication. Other contraindications would include inflammatory bowel disease, previous radiotherapy to the pelvis, a short bowel, poor hand function, poor renal or liver functions. As the bowel would absorb urine, and that would have metabolic consequences. Complications you have early and late, and I won't delve into those at the moment. And if all fails, you would consider urinary diversion. I think I've tried to cover the overactive bladder in this scenario, and I don't think I have other case that I can discuss because I'm short of time, but we can discuss any questions that the audience may have later. Many thanks.
Thank you very much, Dr. Shahzad, for sharing very interesting cases of overactive bladder. And now I would request Dr. Rizwan Hamid to take this screen and share the incontinence cases. As I told in the initial part of the presentation that Dr. Belal was supposed to present his cases, but due to the unfortunate accident, he's not here, and Dr. Rizwan will also be presenting his cases as well. Thank you. Dr. Rizwan.
Fazal, thank you very much for the kind introduction. I will share just 1 second. I hope you can see. So, Fazal, thank you very much for the invitation, and thank you for inviting me. And it's a lovely webinar. I think all of us are enjoying it. I've got 2 presentations, or I've been stepped in for the second one. This is my friend Mohammad Belal and colleague. He's in Birmingham. He was supposed to give this presentation, this one, but unfortunately he met with a tragic accident. He's recovering in the hospital, and we wish a speedy recovery to him. He was to talk on incontinence and female cases, so I have made up some presentation in the last couple of days, and hopefully you're going to enjoy sharing these cases with me. These are my disclosures. Hopefully it will come. So these are my disclosures. These are various companies I work with. What I have done is I've concentrated entirely on the urodynamics. What I'm going to do is to hopefully present some cases and share lots of urodynamic tracings. I'm not going to divulge too much into the treatments. So I want to concentrate on the urodynamics, how to do. My other colleagues have set the scene of what is expected from urodynamics, and I'll try to, I don't know why they are not moving forward, but here we go. So what I'm going to do is to share the urodynamics tracings with you. So there are a few cases. The first case is a 39-year-old with a frequency of half-hourly and nocturia, complains of both urge and stress incontinence, has tried pelvic floor training, anticholinergics with limited benefit, does not complain of any urinary tract infections. I'm not going to divulge the pros and cons, whether we should do urodynamics or not. We are doing it, going on the assumption that the next step is urodynamic studies, which we have performed. So here is a tracing from the urodynamics. And what I want to do is to share with you the urodynamics on the knowledge which has already been discussed with you. So that generally by convention, the red line is the abdominal line. The blue line is the vesical line. As Nazli said earlier on, that both generally should be positive because it's difficult to have a negative pressure inside. So generally you zero the transducers to the atmosphere before you start, attached to the patient, and then you look at the subtracted detrusor line. This line, according to the ICS, can be between +5 and -5, the detrusor line, not the others, because these pressures cannot be negative. And then you do a cuff impulse to see that subtraction is reasonable, which probably here it is. And then you start filling up, and this shows how much you have filled up. So here in this patient, there's a cuff here at around 40 mils. There's no leakage, but as the patient went past 100 mils, these are the cuffs to demonstrate stress incontinence, with both Nazli and Raheela told you that objectively you can see that in the clinic also, which is very true. And here you mark that the patient leaked urine. And as you continue to fill, I hope you can see that this line is going up, which is the vesical line going up. The detrusor line is following that. There isn't much activity in the rectal line, so one will assume that this is detrusor overactivity, and the pressure goes up and up and up, and here it goes up also. Generally, what one tries to do in urodynamics, good practice is that do not give the maturation command unless the pressure have started to come down. Otherwise, if you get the patient to pass urine on a unstable contraction, then the pelvic floor might be contracted and you might not get as good a result as you want. So here you can see the filling was stopped as soon as the patient started to say, I'm feeling urgent. The filling was stopped. The pressure continued to rise for a little while, which is detrusor overactivity, but they started to come down. And when it comes down to reasonably baseline, this you can see is the maturation command was given. And then this is the detrusor contraction where the patient passed urine. This is the accompanying video clip. Again, I'm not going to diverge into the argument and what type of urodynamics one does. I try to do video urodynamics. That's how I've been taught. I think that is the best test. It is that in the video, you can see what is going on. Without video, you can't see what is going on. So here, the accompanying video shows the cuff. So if you can see here, at resting, the bladder neck is below the level of the inferior border of pubic symphysis. And when patient cuffed, it leaks. I'm going to discuss the classification in a second, the Blavis classification, but this will be classed as type 2B. And if the patient is bothersome, then she can be offered surgical intervention. Probably colpo suspension is the one which I would offer. It can be lap or open, but all other options, including slings, are open to her depending upon what she wants. And obviously we cannot ignore the bulking agents. You need to offer patients all therapies, but the one just looking at the tracings will tell us that colpo suspension should work. And hence, this is what you need to do on urodynamic studies. So this is the second case, again, a 43-year-old patient with a frequency of hourly nocturia ×3 and urge incontinence, denies having any stress urinary incontinence, did the pelvic floor exercises and anticholinergics with limited benefit, and we elected to do urodynamic studies. So this patient again has got no stress incontinence, complaining of urge incontinence. Again, vesical bladder line, sorry, rectal line, oh, that is one, rectal line, vesical line, subtracted detrusor, good coughing pulses. You keep filling the patient up. These are mimicking each other. One can argue a little bit of pressure going up, but you can't see any detrusor overactivity, and the patient has got no urgency. So this is the filling phase, filled to up to 200 mils, relatively flat line. You can see both if you see the lines going up here, that means the patient was either stood up or standing up. When these two lines go up together, that means the transfers have been changed, but there is no change here. That means pretty stable. And here, the reverse has happened. And the reason the lines have gone down, we have already discussed, they can't be negative. And the reason they are negative is that the transducers have gone below the patient. So I think this is very important when you have a look at it, see. But it's not ideal, but reasonable. The maturation command was given. You can see good voiding. Now, if you remember going back to the case, this is a patient who has got symptoms of overactive bladder, has not benefited from first line, second line treatment, which is physiotherapy, conservative, and medications. We did the urodynamics with the view of going on to do the intervention. We have not replicated her symptoms. So patients have got symptoms. We have not replicated. What is the next step? You can always treat. But what we recommend is, if you want to have the diagnosis, then go on to do the ambulatory urodynamics. And this, I've put a tracing of the ambulatory urodynamics, and this is the natural field urodynamics. The way I describe is that in the standard urodynamics, you attach the patient to the computer. Here, we have attached the computer to the patient so they can move around in the hospital with the lines in, with a natural fill. I'm not sure how many of you are familiar with ambulatory urodynamics, but it is not difficult. It is time consuming, but you get good test. And we have published that in about 1/3 of the patients in which you cannot demonstrate overactivity on standard urodynamics, you can do that on ambulatory urodynamics. And here you can see very clearly, you can get the transducer work here. Again, abdominal line, vesical line, subtracted detrusor line. You can see they're reasonably well subtracted. And here you go. See, here's the patient was urgent. The pressure urgent, you can see there's detrusor overactivity, activity in the vesical line, mimicked in the detrusor line, nothing in the abdominal line. You can see that it happens here again. So the patient has got clear evidence of detrusor overactivity, and there's a bit of leakage here also, which is picked up in there. So now what we have done is replicated patient symptom with the help of ambulatory urodynamics when there is a negative standard urodynamics. And now we can offer her all the treatments like Shahzad said. She can have posterior tibial stimulation, botulinum toxins, sacral nerve stimulation, and going on with the other treatments. But it is good to have an objective diagnosis, because what you want to do is to find out where we started off from. I think all of us do surgery, and we know that not all surgeries are successful. So you need to know where you started off from. Also, we'll be following up these patients for a very long time. So you want to know what the situation was in, let's say, 2021. So I'm going to move on to a slightly different case. So this is again a 24-year-old lady who went into acute retention post-surgery for endometriosis. And now she is dependent on intermittent catheterization. She had a urethral pressure profile, which I'm not going to discuss today, but it was high at 94. At the way it is calculated is it is a figure of 92 minus age. So for her, it should be around 68. So it is about close to 100. So that is high. So what we did was to do urodynamics. Again, I'm not going to discuss the pros and cons. We're not going to get into that controversy. We have decided to do urodynamics. So what I want to show and share with you how to do urodynamics. Urodynamics essentially is a pattern recognition. You know, when we look at the CT scan, look at an MRI, we are familiar with how the kidneys is, how the bladder is, what to find in hydronephrosis, how to do bladder stone, where the kidney tumor is. This is a pattern recognition. Again, you can see the bladder line, vesical line, subtracted detrusor line. You can see the patient has been filled up. There's not much activity all the way when the patient is filled. Again, look here. Both the pressures go up. That means that the patient was asked to stand up, and both pressures go up, which is normal. And we can discuss the pressures later on. So in the filling phase, the patient was stable, went up to about 305 mils, and then the maturation command was given. So now what happens in the maturation command? And that is why what I'm trying to do is to share with you what information you get from urodynamics, why it is important, and what is the importance of video urodynamics. Because remember, what we are trying to do is to replicate the patient's symptoms, give a diagnosis, and then come up with the treatment options. And here, if you are just doing a standard urodynamics, what you're going to find out is standard urodynamics means that there's no video component with it. So you're doing it in the lab, patient stood up, you ask them to pass urine. Surprisingly, there's nothing coming through. So the pressure goes up in the vesical line, mimicking the detrusor line, nothing in the abdominal line. So it's just not an abdominal contraction, but you can see there's a contraction. What is happening here? So now we've got the video clip, and now you can see what is happening. Excuse me. This was where the maturation command was given. You can see the bladder neck is closed. When the patient is trying to void, she is generating pressure. There's a tiny bit opening of the bladder neck, but no urine is flowing through. And that is why I said this is a pattern recognition. You marry the history with the urodynamic findings. So this patient has got, we are assuming, and you take my word for it, that she has got no bowel symptoms, she's got no sexual dysfunction, she's got no neurology, and therefore she has got is what we now call as isolated dysfunction of non-relaxation of external sphincter. Previously, it was known as Fowler syndrome. So her external sphincter is not relaxing, and it is suitable to have the treatment which Shahzad said of sacral nerve stimulation. But you need to know what you are looking for, what is the question, what is the urodynamic question. So hence, this is very important. And then before you start doing the urodynamics, what is the question? What we are trying to answer? Is it the symptoms are in the storage phase, in the voiding phase, or it's a neurogenic component? It is just like doing the CT scan. We send the patients to the radiologist with a CT scan that they have got, let's say, a stone. The radiologist will comment on the stone. That is the primary thing. But they were also going to comment if they see something else, what we call as incidental finding. The same thing happens. Patients come with a complaint. We set up the urodynamics to answer the urodynamic question, but during the investigation, if we find another abnormality, then we report on it. So I'm going to move on to the next case. Again, I just want to emphasize, I am discussing the urodynamics, how to answer. This is the history. When we do the urodynamics, what we are trying to find out. This is a 47-year-old patient, hourly frequency with some urgency, report a small volume leak shortly after voiding. So it's important, it's always important, like when you're doing an exam, we're always taught to look at the question. There's a small volume leak after voiding, difficult voiding in sense of incomplete emptying, and the free flow Qmax of 19, voiding to 14, left a residue of 180. We elected to do urodynamics. See. So there is again a urodynamic trace. Again, I'm not going to go now. I think you're familiar. After 1 minute, according to ICS, one should ask her to cough to make sure lines are subtracting well. We asked her to cough 3 to 6 times. That's what you should do. There's no stress incontinence, filled up to about 500 mils. One can argue there's a bit of detrusor overactivity here. Then asked to pass urine. Well, here, good voiding pressure, good flow. Probably she's not obstructed. What is going on? Again, we have not replicated a symptom on the standard urodynamics. I'm trying to convert you to go to the video urodynamics. This is what, if you're doing an accompanying video, this is what you see. Now, if you go back to her history, she said, she's got frequency urgency, and we have shown detrusor overactivity, but she said, I leak a little bit after I have passed urine. And here you've got the diagnosis. She has got what is a urethral diverticulum, which fills up as she voids. And that is why a little bit after finishing voiding, she leaks. So hence, this is the importance of video urodynamics, is that you can actually find out the diagnosis. Now we need to treat this first. We know she's got bladder dysfunction. And generally, as a rule of thumb, not necessarily with a urinary tract, you treat from below and go up, or rather than up and coming down. So this is a classical urethral diverticulum. Now, what is bladder outflow obstruction in women? And I'm going to share a few slides with you. If you look here, and that is why I am a great fan of video urodynamic studies. I agree with Nazli and Dr. Raheela that everywhere urodynamics is not available. And I completely agree. And Nazli made a very good point that you can get a lot of information from frequency volume charts and uroflowmetry, and probably 90% of the time you can do that. But it's a kind of a, as the cases get complex, we should in a way up our level, and on those cases, we should do selectively these investigations. So I completely agree, every patient who walks through a functional urology or urogynecology clinic does not need video urodynamic studies, but when the history suggests, or they've got a history of previous surgery, of the 100 cases we see, that is less than 10%, those are the patients who need to have these, what we call is as complex investigation, and probably video will be on that. So here you can see a stricture just above, and there's a ballooning. So this is a female stricture, and then it can be treated by dilatations, or nowadays we like to do a female buccal mucosal urethroplasties, which I do, not in every case, especially in young women. You don't want to do the dilatation all the time. What's happening here? Dr. Raheela showed a very nice case of prolapse. This is what is happening. A cystocele is kinking. That was a different prolapse, by the way. So, but this is a cystocele which is kinking. So the patient might present with obstructive symptoms, hence the importance of clinical examination. And here you can see that she has got kinking. So here can be a situation where she's got stress incontinence, but voiding dysfunction. If you do the urodynamics, this is what you find out on the video clip, and then you can treat her appropriately. What about this? This is a patient who had a TVT, which is done by Shahzad. No, not really. I'm just joking. He's here, so I'm saying that. So basically, the tape has been quite tight, and that is why you can see a classical obstruction where the tape has been put. You can find that out on video urodynamic studies. Now, she complained with obstructive symptoms. Quite often, these patients will have persistent stress incontinence and obstruction. So you need to have an algorithm. And generally what I will do is to release the tape make it very clear to the patient that her incontinence might get worse, and then treat it. Sometimes these patients will say, I'm happy to do self-catheterization if they are dry, but you get the diagnosis. So always think that in complex cases, it is just like our oncology friends. If somebody goes with them a high PSA, they're not going to do the radical prostatectomy straight away. They ask nowadays for MRI and PSMA and PET scan and this, that, and the other. So I think as a functional urologist or urogynecologist, we should not be inhibited by asking the test in the small subset of patients where the management can be changed or they are complex, and we should raise our hand, and sometimes we cannot deal with every single case. So we get the diagnosis and send it to somebody, because like most other things in life, first attempt is the best attempt. This is avoiding dysfunction of that idiopathic non-relaxing sphincter, and you can see the sphincter is contracted here. There's a ballooning and there's relaxed. This is what normally should happen, and this is what the contracted sphincter is. So then you get your diagnosis. So it's a bladder outflow obstruction in females. There are 4 or 5 different things. You need to get the diagnosis right. Otherwise, one can do one operation after the other, and then the patient is still not better and unhappy. In the last few minutes, I'm just going to share with you the classification of stress incontinence as we do. This is a Blavis classification. Again, if you do it on video, you can see type 1 is when the blood neck is above the inferior border of the symphysis. There's a leak, but the descent is less than 2 centimeters. The importance of this is type 1, type 2A, 2B, and 3 is then you can then ask the patient, you give them all the options, but tell them this is the treatment which might suit you best. This is type 2A, where again, the blood neck is above the lower border of symphysis, but the descent is more than 2 centimeters and there's a leak. So this is type 2A. What is type 2B? Like we had in the first case, that the blood neck is below the level of the inferior border of symphysis, further descent and leakage, which is type 2B. And classically, before and now, we use the corpus suspension, whether lap or open, for this problem. What about the last one, which is type 3 incontinence? And this is where it calls as intrinsic sphincter deficiency. Generally, the patient will be incontinent even with lying down. You can see it's completely open, and probably most of us will agree that this patient will require, again, all options are open, but generally you require a rectus fasciae sling or a mid-urethral sling for this type of incontinence. I think probably that is all I've got for the incontinence part. Again, I've put some slides with my friend Mohammad Belal here. We've been enjoying in various conferences, and we all pray that God gives him full health and he's back with us very soon. Thank you very much.
Thank you very much, Dr. Rizwan, for sharing very interesting cases. I think the next presentation is also with you about the neurogenic and the complex cases.
That is correct. I'll just open that presentation in a second. So again, I hope you can see the screen. So again, thank you very much. This is what I was asked to talk initially, and that is the neuro and complex cases. Again, I work at Stanmore Spinal Disease Unit and UCLH, and thanks, I don't know why these are again my disclosures. They are same, they have not changed in 10-15 minutes. So again, I've done the same thing. I am going to concentrate on the urodynamics evaluation of a given case. I'm not going to diverge too much into the controversies or the long-term treatments. It is that we have got a case. When we do the urodynamics, what do we find and how we go about? So here I've got a case. It's a 27-year-old man who's got a T6 spinal cord injury about 18 months ago, not on any medications, empties by a Crady maneuver, and complains of recurrent infections. So we elected to do urodynamics. So this is the urodynamic trace in that patient. Again, remember I said that urodynamics is pattern recognition. So there are various patterns, like in radiology, various patterns come up and then we go by that. So this is a classical trace of a suprasacral spinal cord injury, where we have got a classical sawtooth appearance because of detrusor sphincter dyssynergia. In the neuropath, we do exactly the same as non-neuropathic patients. They get the abdominal line, the vesical line, the subtracted detrusor line. You get a cuff to see this subtraction is good. You fill the bladder up. You can see you fill up to a point here. This is actually 5 minutes, and then the pressure goes up. Nothing initially much happens in the rectal line, but you can see the pressure goes up in the vesical line, mimicking in the detrusor line, and this classically sawtooth appearance which goes on and on and on. And this is very important. Whole of the neurourology is around this overactivity or high pressure bladder in the filling phase, because as I think it was Nazli who alluded to in our talk, the compliance and loss of pressure. And this comes from, I think, a study from McGuire probably, was it McGuire or spina bifida, where it said that if the pressure is, in the resting pressure is more than 40 centimeters of water, then the upper tracts can't drain. This was in spina bifida boys done 40 years ago. We still use that because if the pressure is more, and here you can see it is much more than 40 and is sustained for a long period of time, then the upper tracts can't drain, and that is a dangerous situation. Now, it is recommended that especially in the neurogenic patients, you should do an accompanying video. And this is what the video will show. In the same case, you can see that the external sphincter is contracted. There's some ballooning up of the prostatic urethra, and this is the bladder. And that is what happens in detrusor sphincter dyssynergia, where the bladder contracts, the sphincter also contracts, and then you can argue why there is a sawtooth thing. So if I go back, then one can argue why you are seeing this. And the reason for that is that the external sphincter is a skeletal muscle, so it does like this. It cannot contract continuously, while detrusor is a smooth muscle. It will continue to contract. It can contract for a long period of time. So the reason is that as the external sphincter relaxes, a little bit of urine comes out, the detrusor relaxes. So then this thing happens, which you can see a classical sawtooth appearance of sphincter dyssynergia. And if we don't treat this, then you end up with this situation, which is trabeculated, sacculated bladder. It is known as a fir tree bladder or a Christmas tree bladder. And this is what you don't want, because the next step would be that you can see bilateral hydronephrosis, hydroureter, and kidney failure. Just tracing was similar. This is what is the loss of compliance. So as one fills up, you can see the vesical pressure goes up, the detrusor go up. And the difference between this, so this is the loss of compliance where the pressure continues to go up. One can argue that when this is overactivity and the pressure comes down when you stop it. So the difference between the true compliance and artificial compliance is that in the true compliance, when you stop filling, it stays there and then continues to go up. In the artificial, you have been filling it too fast. So when you stop, it comes down and you fill slowly and it stays down. So that is why Shahzad alluded to that it is very important to do a frequency volume chart before you do the urodynamics, so you see what the functional capacity is. So if somebody's got a capacity of 150 and you start filling them up at a speed of 100 mils per minute, after a minute, they will have loss of compliance. On the other hand, that 24-year-old lady with endometriosis and no feeling, she might have a capacity of 500 mils. If you start filling her at 20 mils, you'll be there all day. So you need to know from the frequency volume chart and then adjust the fill rate. And the ICS recommends that for the neurogenic patients, it should be about 10 to 20 mils per minute. So we come to our second case. And this is a 35-year-old spinal cord injury patient. He's got an indwelling suprapubic catheter as a means of bladder drainage. So the injury is C4. Complains of occasional infections, is taking anti-muscarinics and clamps catheter irregularly. So we want to find out what are the urodynamics parameters on this patient. I'm going to go back to saying it's a pattern recognition. So some of you who have not seen this before say, what is this? Either this is not done well or I can't understand. On the other hand, those of us who have done this test without saying anything, even if I've not told anything, given no history, he or she would straight away say, this is the urodynamic, which is done via the suprapubic catheter or an indwelling catheter, because it's a classical trace which we get with when you do the urodynamics with catheter. Again, pattern recognition. You put a line in the abdomen. There's a vesical line which is attached to the suprapubic catheter with a 3-way tap. So it's the same line. And that is why when you open the tap, it's the same line which you are using for infusing and filling. And that is why you get this. So from time to time, you stop it and the pressure, you stop the flow, hence the pressure drop. So this is the actual pressure. So it's periodical, but you can see it is going up slowly. It started off reasonably well near 0. And as we filled up to about 400, it has gone up to probably 15 centimeters of water. So this patient, what was the urodynamic question? Why did we do it? So we wanted to see that in the cervical spinal cord injury patients, are the resting pressure acceptable and not very high, or it hasn't got a loss of compliance? Now, excuse me, we need to know what is normal if we want to know what is abnormal. So what is the normal compliance? And that is for every 40 mils you infuse, according to the ICS, you are allowed 1 centimeter rise in pressure. That is why if you infuse about 400 mils, if the pressure goes up to 10 centimeters of water, that is normal compliance. If it goes above that, then it is abnormal. Also, what needs to be kept in mind is that the ICS only standardized it to about 400 mils. So if you put in 800 mils and the pressure goes up to 40 centimeters, that does not mean that it is abnormal, because that is not standardized. Generally, one should not fill beyond 500 mils in urodynamics. You need to have got your answer by that time. So in this patient, you can see there is a loss of compliance developing. So you want to be proactive. Taking medications has not worked. You might consider injecting botulinum toxin, because what you want is the resting pressures to come down so that the filling pressures are down, the upper tracts are not under any pressure. It's a classical, so pattern recognition, classical trace done with the catheter. So now we move on to our next case. That is a 49-year-old male. He's got spina bifida. He's voiding on urge. He's been incontinent. Self-catheterizes, got constipation. He's in renal failure, recurrent infections, epididymoarchitis. That means that he's not doing very well. There's a high pressure. So what did we do? We got an ultrasound scan, and here you can see it's got hydronephrosis, probably clubbing of the calyces. So we did the urodynamics. And here you can see, again, vesical line. This is the abdominal line. This is the detrusor line. You can see both are mimicking, both are going up. As the pressure goes up, this goes up. Nothing is happening here. And when you do the accompanying video, horrible looking DST, blown up prostatic urethra. That is why it's getting epididymoarchitis. See, you marry everything together, classical fertile bladder. Then you can agree that this is the patient probably is not going to benefit from Botox and medications. So you need to do probably cystoplasty. Before that, you need to do a MAG3 in this case, and that's why you need to think through sequentially. The reason of doing a MAG3 was it's obstructed. Do you want to reimplant the ureters at the same time? It's a bit controversial, but generally most of us will agree that if you can bring the pressures down, then the ureters start to drain. But in this case, if the pressures are high and you put a catheter in and still the ureters are not draining, then you need to do the bilateral ureteric reimplantation. So the patient had a bilateral ureteric reimplantation with double clamp cystoplasty, and when the routine post-operative course did reasonably well. After that, no leakage, some mucus in urine, self-catheterization, the creatinine came down. So sometimes you need to understand that you're not going to make it completely go back to normal. What you're trying to do is to stop going down the slippery slope of renal failure. But have we achieved our objective? And how we check it? We do urodynamics. And here, post-operative urodynamics shows that now they can hold up to about 450 mils with a little bit of overactivity, but generally a very good urodynamic trace. And that is why, remember I said, that's why you do the urodynamics before major surgery, that if you don't achieve your objective, you know where you started off from. And this is the urodynamics after. So I think probably we'll agree that we have achieved our objective. It's a reasonably shaped bladder. Not much is happening here. Filled up to 440. Capacity is about 600. There's no reflux. So I think we have achieved our objective. So now I'm going to go on to discuss some other complex cases. Those were the neurogenic cases. This is a 69-year-old male, frequency urgency with nocturia, difficult voiding, poor stream. He had a TURP before, and that is why it becomes complex. So if he had no TURP, probably you do a flow rate and go on to do the intervention. But here what you would like to see is, this is the flow rate. You can see a classical pattern recognition, classical stricture flow. So I want to do urodynamics on everybody, and I did the urodynamics. And see what happens. It's got a stricture. You can see as you fill up, and now we have replicated its symptoms. It's complaining of frequency urgency. We have outlined, it's got classical overactivity, very high pressure overactivity, probably leakage. And then this all overactivity, maturation command was given, poor flow, and you can see on the accompanying video that he's got a post-TURP stricture. So now we've got a good diagnosis. And the importance of this is that in the management, you're going to discuss with the patient, if you go and deal with the stricture, probably you're going to make him incontinent. So this is very important. The reason he's continent is the stricture is keeping him continent, but giving him voiding dysfunction, which has secondarily caused to overactivity. So it's a complex case. So you need to, again, like I said, work from down below. Ideally, you deal with the stricture, probably with dilatation, stabilize it. Maybe you end up making him, giving him stress incontinence. Then you need to do the sphincter or a male sling to make sure that he's continent. 50% of the time, we know that overactivity is going to settle. If it does not, then you deal with that. So again, you work your way from down up, thinking and discussing with patient that when you do whatever you are doing, then what are the consequences or sequelae of your treatment would be, and think on those terms and discuss with the patient. Next case is a 36-year-old patient, hourly frequency with nocturia, voiding difficulties, and feeling of incomplete emptying. So where we are, free flow, 12, voided volume 220, left a residue of 100. Now this was a young man, so this is different. It's a young man, primary presentation, and I think most of us would agree that in a young man who comes with voiding dysfunction, this is my belief, I think it's a disservice not to do urodynamics and not to do video urodynamics before the treatment. Here you can see, again, pattern recognition. Normally, if there's activity in the detrusor line, you say this detrusor overactivity. Well, nothing is happening in the vesical line. And that is why we put the rectal line in, because you want to find out what's happening in the abdomen. So maybe it's not opened his bowels or it's got irritable bowel. So now you ignore this. You don't report this as overactivity. This is the line. There's a little bit of, I won't say loss of compliance, but maybe pressure going up. But he's got no overactivity, so you concentrate on this line. So you fill the patient up to about 450, 460 mils. Nothing happens because it's stable fill. Here, the patient was asked to stand up. You can argue that a little bit of activity here, but now the maturation command was given. And here's another fallacy. You can see this because we were moving the urinal, adjusting, so it has recorded a very high flow rate. And hence, please, please never, ever, I mean, there are no absolutes in medicine, but do not report the urodynamics from what you get the computer-generated figures. That is completely wrong. And here, the computer will tell you there's got a flow rate of about 120 mils per second, while we know that it is less than 5. And that is why it's a computer artifact. And when we hopefully, like Fazal said, do our proper urodynamics course, I will share with you lots of these artifacts and how to mitigate them. But that is why the patient generates a very high pressure very poor flow, you ignore that. So what is going on? And that is why you need to do the video urodynamic studies, because if you do the video, you can see at this level, when the pressure is going very high, bladder neck is not opening very well, and there's a poor flow. And then you do a stop test known as white side trapping sign. And now you can see that it is in this area, when the bladder neck closes, so patient is passing urine, you ask them to stop passing urine. As soon as it stops passing urine, there is a trapping of the contrast between the, there's a trapping of the contrast between the bladder neck and the prostatic urethra. This is a classical sign of bladder neck obstruction, white side trapping. So now we have got our diagnosis. Now what do we do with this 36-year-old man who has failed the medical therapy? And this is a difficult conversation to have. You can double the dose of antimuscarinics, which one of my Pakistani friends told me works very well. I never used to do it up until 2 years ago. If he has completed his family, you can offer a blood, neck, and semen. If he has not completed his family and is very much bothered, then you can have the semen storage and get Nazli's help later on to do IVF or ICSI or anything like that. Or what you can do is to do a limited bladder, neck, and semen with a less chance of giving him a retrograde ejaculation. But all these things need to be discussed. But you need to have the diagnosis before you can go on to have this treatment option. I think I've got 5 more minutes, isn't it? I've got some time. So
yes, Rizwan, you have 5 minutes more.
Yeah. So this is a 68-year-old male, again a complex case. It's got CA prostate, had radical prostatectomy and radiotherapy. Not surprisingly, I've got lots of frequency urgency, nocturia and urge incontinence, and stress urinary incontinence also. You already had artificial sphincter for incontinence, but the symptoms are still persistent. So what we do, we always do urodynamics, but this is a test which I want to share with you, which we have popularized at UCLH. It is known as a retrograde leak point pressure. I'm going to go. So basically what you do is to take a small, cuff, put it around penis, and then put the line in first. It only goes till the penile urethra and occlude the cuff so nothing can come back, okay? And then what you do is to slowly start filling up. And you can see here that you can find out what the leak point pressure is. Again, what is the urodynamic, what is the urodynamic question? And as you fill up, you can see nothing is going beyond and the pressure is going up, up, up. It goes up to about 50 centimeters and then stabilize starts to come down because now the fluid has gone past that. That means that that is the artificial sphincter resistance or the sphincter or the resistance offered by the external sphincter. So in this case, he had an artificial sphincter, and what it can hold against a pressure of 60 centimeters of water, which by and large is quite good because normally when we put a cuff between 61 to 70 centimeters of water. And the importance of this in this case is that if he is leaking and having stress incontinence, then if you want to do something, you have to either upsize the balloon or downsize the sphincter to increase the pressure. If he didn't have an artificial sphincter, and let's say he leaked at around 40 centimeters of water, you know the external sphincter is weak, and then you offer surgical treatment. So this is important. On the other hand, if it leaks at 60 centimeters of water, and probably that is an overactivity, then you need to have this discussion with the patient that maybe the sphincter is working all right. It is just that the pressure in the bladder is so much, 100 centimeters of water, which we can, I think probably we have got the next slide. It goes, yes, here. So you can see whenever the pressure goes above 60, 70 centimeters of water, then it will leak because artificial sphincter has got a fixed sphincter, fixed resistance. So when the pressure goes above here, very high, then he is going to leak. And hence that needs to be kept in mind. So in this way, somebody who has got radiotherapy, stress incontinence, you have put an artificial sphincter, they are still having incontinence, you need to figure out that here you can see from a very early on, as soon as you start filling, there's a loss of compliance, overactivity. So here the problem is the bladder. So if you concentrate, upsize the balloon, downsize the sphincter, that's just probably not going to be that helpful. So you need to treat here the bladder first, maybe with botulinum toxin, or maybe you want to do cystoplasty. Get the pressures down, get the capacity up, and then come and do it here. So you need to know what is going on. And then, like I said, you treat from below up, but in medicine, there are no absolutes, and you need to know what is happening in the bladder, what is happening in the urethra. It's a reciprocal function, and that needs to be taken into account. That is all, Fazal. Thank you very much for inviting. That's very kind of you. I think we had a good session, and this is my city, the beautiful city of London. I think it's the best city in the world. Thank you very much.
Thank you very much, Rizwan. You did an excellent presentation on both aspects of the incontinence as well as the neurogenic and the complex cases. Rather, you made the complex cases very easy. So I think we have all panelists with us now, and we have questions. Dr. Nazli, you are with us now? Dr. Nazli?
I couldn't have left, with such good presentations.
I think we have to make one announcement for the participants that is that we have posted the link in the chat box, and following this link, I think the participants, they can claim their e-certificate. So Dr. Nazli, the question for you is that what is the minimum voided volume which should be there to document the good uroflowmetry? And the second question is that why it is imperative to get urine culture and sensitivity before performing a urodynamic study?
So first, let's start with the culture. It's important because it's an invasive procedure. You're passing in catheter. And I didn't say necessarily catheter, but the culture, but if you need to have a good urine DR specimen, if it doesn't show infection, then no need to do culture. Otherwise, you do a culture to exclude any pre-existing infection before you perform urodynamics, number one. And number two, for a good uroflowmetry, a proper curve will be obtained if at least 150 to 200 ml of urine is there. If it is less than that, obviously you'll not get a classical curve, but it's not like something that, at least not that I know of, that this much of urine should be there before you perform a uroflowmetry.
And Nazli, how to avoid the artifacts? I mean, as Rizwan rightly pointed out, that sometimes you get the uroflowmetry curves and depicting the flows in the 60s and 17s, sometime in 100. So what should be the precaution?
You just have to reduce the zero errors. You have to know exactly. You have to know where you've started. Your transducers are at zero pressure. You should not be filling in too rapidly. You should not be filling it with too cold a solution. And similarly, the patient should not be talking too much during that procedure, because that will create artifacts. And so these are the steps that you can take to minimize, but obviously you need to be aware of this. If still you see those artifacts there, you need to recognize them because they do not fit into a pattern.
So my question with the Professor Raheela is that what is the role of profilometry? Where do you see the role of profilometry if you are planning to perform the surgery for the stress incontinence?
So the urethral pressure profilometry is equivalent to Valsalva leak point pressure. So if it's a good machine, and if there's an automated movement of UPP extender, like we have with the MMS, we have a good machine, and the other machine I know, the Labori system, they also have a good extender with to measure the urethral pressure profilometry. So when you click it on, the tick, tick, tick things that slightly move the urethral transducer and gives you the mean urethral closure pressure. But if there's in Pakistan, my own observation is that a female urethra is never more than 2 centimeters. And with para 5, female urethra is only 1 to 1.5 centimeter long. So hence my 20 years experience says that UPP has no major role to establish a diagnosis of urodynamic stress incontinence. However, I prefer Valsalva leak pressure profilometry, which is a test where it's a choice on the machine. You click on it, you fill the bladder retrograde filling of 350 ml. You ask the patient to cough. With the increase in abdominal pressure of 60 is the cutoff range minimum for IST, and 120 is the upper range for the urethral hypermobility. You have to have a close observation, as somebody said, that you have to be there. You just cannot rely on the machine printouts. So when you see there's a real rise in the abdominal pressure in the absence of detrusor contraction, only then you establish the urodynamic stress incontinence. So mean urethral closure pressure of less than 40 centimeter of water and Valsalva leak point pressure 60 centimeter of water and less is ISD. 60 to 120 is hypermobility, and 120 above is again very challenging. So that requires another webinar. So what do you do when the abdominal leak point pressure is 120 centimeter and above? So I guess for the female urethra, we have to rely on Valsalva leak point pressure for the urodynamic stress incontinence, and very rarely for my fellow's research paper, we have done the urethral pressure profile test. I hope that clarifies the question.
I think Professor Raheela very well answered. So Dr. Shahzad, what is your threshold for offering patient a botulinum intravesical therapy for someone who is experiencing the symptoms of the overactive bladder? And will you be doing urodynamics in such patient before offering the intravesical botulinum therapy?
Many thanks for the question, Dr. Fazal. Yes, so people who failed the first and second line treatments, which is lifestyle change, losing weight, bladder training, they then go on to have pharmacotherapy with the anti-muscarinics or beta-3 agonists. And if they fail these initial treatment options, they then go on to have urodynamics. That's standard. And we can't inject Botox without having done urodynamics. And then also that patient needs to be discussed in an MDT, which then the pharmacy would only give us the Botox then. And so patients who've failed pharmacotherapy and we've documented detrusor overactivity on urodynamics and discussed in an MDT would go on to have Botox. And we would typically inject 100 units for idiopaths and 200 for new.
Thank you, Dr. Shahzad. So as an endourologist, Dr. Rizwan, what the common patients commonly we see is that patients having the past history of neurogenic problems like stroke, or someone who have got the chronic neurogenic illnesses like Parkinson disease. So, and simultaneously, if patients are experiencing the symptoms of bladder outlet obstruction, so what would be the strategy to deal with such patient, especially if the medical therapies, you have run out of option and a patient is a possible candidate for the transurethral surgery?
Thank you, Fazal. Again, what we are trying to achieve is what is the urodynamic question. So in neurogenic patients, it's two. Either we are doing it for surveillance, i.e. they've got a stable or a progressive disease like multiple sclerosis, and we want to see whether upper tracts are safe, then it's different. But your question is different, and that is that they have got bothersome symptoms, failed therapy, and we are looking towards a surgical intervention. Especially for the Parkinson's patient, I think it is mandatory, to my mind, and I think as the EAU guidelines also say, that for neurogenic patients, when you are planning to do a surgical intervention, you should do urodynamics. And that should be probably video. And the reason for that is we want to find out that what the detrusor is doing, because some of these patients will have detrusor underactivity. So you don't want to operate on them. And also if they have got classical obstruction. So an example will be a 75-year-old male who has got Parkinson's for the last 6-7 years, has got worsening symptoms, and is on the history is avoiding symptoms which are predominant. So I will do urodynamic studies to demonstrate that he has got high pressure, low flow, and then all options for bladder outflow obstruction from TURP to laser to now resume, urolift, all should be available to him. We have now shown, in contrast to previous year or 30 years ago, that patients with Parkinson's do benefit from outflow surgery, but what we must do is to make sure that a neurologist is involved and they have not got multi-system atrophy, because those are the patients who do terribly badly with outflow surgery.
And similarly, Rizwan, the other type of patients, the patients who are having long-standing bladder outlet obstructions and have the ultrasound evidence of detrusor underactivity in the form of high residual volumes. So what would be the cystometric criteria for such patients that they will benefit from surgery or they will not benefit from the surgery?
It's a very interesting question. And up until 2 years ago, what we thought was that if somebody has got chronic retention and you do urodynamics, both on the ultrasound scan and on the urodynamics, they can't generate any pressure, then the outlet surgery should not be done because they will not benefit. However, over the last couple of years, including ourselves, and mostly it's come from America, the evidence is that in these patients who are in retention and you do urodynamics and they can't generate any pressure, or what we'll class as a pressure of less than 50 centimeters of water, so hypocontractile, if you do surgery on them, more than 50% will actually benefit from it. So it's all part of the constant. So you do, and that is why it's important to do the urodynamics to demonstrate where they are, have a chat with the patient and tell them that there's a good chance, probably 50 to 60% chance that you will be able to pass urine, but if you can't, then you'll be dependent on catheters. But the answer is yes, they can benefit from outflow surgery.
And Shahzad, what about the patients who are having the neurogenic bladder and the micturating cystourethrogram is demonstrating the vesico-urethral reflux? So what would be the pitfalls in performing the urodynamic studies in this patient, or in the interpretation of the such studies, what would be the difficulties?
I think the urodynamics is basically a diagnostic investigation, and what you are trying to gather is whether the patient has a safe bladder or does not have a safe bladder. And I think that's the only answer you need. So if there is evidence of vesico-ureteric reflux, you've shown that to be an unsafe bladder, and then you go on to manage those patients. So if you can see VUR and the patient has high, as Dr. Rizwan said, if the PDET is more than 40 centimeters of water, you've got a rising creatinine, and you've got evidence of vesico-ureteric reflux. So all in the context of the overall patient, I think that is enough evidence for you to proceed further to reduce the pressures in the detrusor. And so you can start off with ventricle. It all depends on how bad his initial problem is, whether he's got good hand dexterity. And so well, the aim is to reduce the detrusor pressure, basically. I don't know if that's answered your question.
Yeah. So thank you very much, Shahzad. I think you answered it very well. So Professor Raheela, regarding the prolapse patients, so what is your policy? So you would like to get the urodynamics in each and every case, or do you have some selection criteria for such patients?
All right. So for when a patient comes with prolapse, and if she's really symptomatic, and if you can see the objective cough test for the SUI positive, we don't do any testing other than UFM. We make sure that there's no obstructive, like there will be an element of obstruction secondary to prolapse, urethral outflow obstruction, but then the intrinsic obstruction pattern is definitely different than the extrinsic obstruction. So in the simple case where the patient is symptomatic, the duration of stress incontinence is more than 3 months, the impact on the quality of life is severe, we don't do any testing, we just do a sling, which may be a TOT, or depending on the availability one, and depending upon the amount of leak. I usually go for TVT if the patient is young, has good number of years to live on, and the stress incontinence is really bad. For example, as somebody said, that the cough test is positive in supine, and which means though even we are not doing urodynamics, but still it signifies a very bad SUI, because in supine there's hardly any impact of abdominal pressure, and yet if a patient has leak, then probably it's going towards the ISD side. So the slings have evidence-based efficacy against both type of SUI, while the Birch Karpus suspension is more for the urethral hypermobility. So in a simple case, I won't do urodynamics, but yet comes another case when there is a stage 4 prolapse according to quantification, which means a huge prolapse. Patient is not very symptomatic, occasionally leaks on coughing, sneezing, or laughing, or walking around, but is worried. As I said, that the one possibility is that she may have occult SUI because of the massive prolapse. The angle between the bladder and the urethra is also lost. Once the prolapse is corrected, then the intrinsic SUI can become revealed. Occult SUI can become revealed. And the other thing, that when we dissect a lot, we do a lot of dissection during vaginal hysterectomy for massive eversion, bigger degree of prolapse. So in that case, the patient wouldn't understand what was occult or what was de novo, iatrogenic SUI. In that case, you need to have a good counseling session that, look, you don't have at the moment this SUI thing, but once I correct this massive eversion, the huge prolapse, might as well become symptomatic because of my dissection, or because you may have it, but prolapse is hiding this. So if you understand, can I please put in prophylactic tape? So just in case that you may not leak when you cough, sneeze after the surgery is done. So 50% of patients in Pakistan, they do give consent for prophylactic tape, which is a good news. And we do UFM in all the cases before we put in a tape. So, and this prophylactic tape, my choice is transobturator tape, never TVT. Because that leads to, I think if you compare these two, TVT leads to more voiding dysfunction if you compare it to the TOT. But there's a third case that the patient is not symptomatic, has a major degree of prolapse, and is not convinced by our counseling method for the prophylactic tape. So in that case, there's a 50% chance that patient would have SUI after the surgery, and 50% chance that she may just run smoothly through the post-operative course. To your good luck, if the post-operative course is smooth, then nothing happens. But yes, if she develops this SUI thing, once the surgery is done, maybe by the uterosacral ligament suspension or sacrospinous fixation, these are all pelvic dissection things, which has, even the book says, the journal says, they have some element of de novo SUI. So if the patient develops, and then if you take her back to the counseling session that, well, we did discuss this, and at that point in time you were not convinced, so take your time. If it really is bothersome for you, if you want to establish a diagnosis, I can do a urodynamic. It would establish a diagnosis of urodynamic stress incontinence. But if you don't want to do that, take your time. You have been through a major surgery. Maybe after 6 months, we can have a daycare surgery of TOT. So that's how I'm dealing, practically speaking. I would love to hear from you guys if you have another method of dealing with such cases. Thank you.
I just want to add that normally what I would do is that in the counseling session, when you put a pessary in, you can do that. If you put a pessary in, you can be reasonably certain, because when you put a pessary in, you have actually, corrected the prolapse, and the stress incontinence will present itself. If it presents itself, and that's, to my understanding, that's what the literature shows, that if you do that, then you can do concomitant stress incontinence. If you're done with the pessary and they've got no incontinence, then probably they should not develop incontinence. That's how I deal with it.
True. Agreed. We do that sometimes.
So I think we have answered most of the questions which were asked from the participants of the activity. So are there any comments from the faculty?
I think it's been a lovely session. Thank you so much for organizing all this. Thank
you, Dr. Shahzad. So I think then we can move on to Dr. Aasem Chaudry for his concluding remarks.
Assalamu alaikum, everyone. I think it was a wonderful session, and we all benefited from it. I think it is just I think we all saw that this area of urology is, as we see it, is a huge subject and a vast area. It's impossible to cover the or to do it properly in a short period of time. The idea of the program was to provide a bird's eye view of the whole subject. And I'm happy to see that a lot of trainees also joined in. And one of the objectives is for our younger urologists to develop interest into this field. And particularly so in Pakistan, we need a lot more urologists with a specialty interest in bladder function. And what we want to see is every major urology unit have facilities to assess bladder function with appropriate tests, including video urodynamics. We all need to work hard towards achieving that objective. And I think we also saw through this program the usefulness of collaboration and the opportunity we've got through the current electronic facilities that we have, that it is possible to collaborate and exchange the expertise across the countries and help and benefit our patients. And I think a few very important take-home messages. I think all the presenters, Professor Nazli, Dr. Raheela, Dr. Shahzad, Dr. Rizwan, everyone did excellent presentations. And I think we have to thank them and thank everyone who attended the program. I think the message that comes out of all the presentations and discussions, that this group of patients require individualized approach. We use the science and the expertise we've got to benefit them and to develop the ability to use these modalities properly where indicated. And inshallah, work with all these things to benefit our patients. And I must not forget or remind everyone that we must make special dua for Dr. Belal, who unfortunately couldn't join us because of an incident a couple of days ago. May Allah subhanahu wa ta'ala bless him with full recovery very soon, and he is able to join us in future. Going forwards, I think it'll be good to have some comments from the faculty in terms of moving forwards on this subject. I think we do have a plan to hold a 2-day workshop on the subject, which was initially scheduled last year, but couldn't happen because of the COVID situation. And let's hope and pray that we are able to hold that workshop in the later part of this year. So over to you.
Well, I would just say, Aasem and Fazal, thank you very much. And obviously thanks to the Getz Pharma for organizing it. And it's a huge effort to organize this. And we had close to 200 participants. And so that is fantastic. That means there's a lot of interest, and I'm sure there should be. Like you, I'm passionate about functional urology, and I think urodynamics is the cornerstone of all this. I think the next step to my mind would be to have, hopefully, inshallah, when this COVID passes by us, to have a hands-on couple of days conference. And then I think probably, like Nazli pointed out, that this needs to be a continuous effort. So you can't, or you should not do one and then just forget about it. It's a continuous thing. You need to do it over and over again. But the starting point, to my mind, next would be, if possible, we can have a hands-on workshop and then see how things go.
I think that's really a very good idea. Yeah.
So I think I would like
Fazal,
to
can I just say thank on behalf of Royal College as well, please? This is an absolutely fantastic event. Clearly, since finishing residency, I've not been in touch with this subject. It was a fantastic refresher, not just for non-urodynamic practicing consultants, but I'm sure for residents as well. And I would really hope that we continue this collaborative process between Royal College and Pakistani institutes for this kind of education promotion and leading from webinars to hands-on in the future. Thank you very much.
Thank you very much, Zeeshan. We are really thankful to you for getting our activity accredited from the Royal College of Physicians and Surgeons, Glasgow. And we are also thankful to the Pakistan Association of Urological Surgeons for accrediting this academic activity. I'm really thankful to all the faculty for sparing their precious time for this webinar. And I think, as Rizwan has rightly pointed out, that the way forward should be a hand-on activity in the near future, whenever the COVID situation permits us. I think we would love to have our faculty with us to have a hand-on workshop. And I'm thankful to all the participants who have joined from the different parts of the world for participating in this academic activity. Thank you very much. Have a nice day. Thank you.
Thank you very much.
Thank you so much.
Thank you.
Thank you. Thank you so much, Dr. Fazal, for inviting us, and always at your disposal for such an academic activity. Always.
Thank you, Dr. Nazli. Thank you.
Thank you very much. Bye-bye. Bye.
Okay.
Allah Hafiz.